Welcome to Collaborative Intensive Bridging Services, otherwise known as CIBS. CIBS was a service developed particularly to help at-risk youth and their families. Now, these children were typically the type of kids who would go to long-term residential treatment centers. And back in 2009, Dakota County was experiencing just that situation. Many of their children were going into residential treatment centers and were staying there longer than expected, or they were going in for multiple episodes of treatment. And Dakota County asked the question, how can we do this differently? The result was the formulation of the CIBS model. Now, CIBS is pairing intensive in-home therapy along with a short-term residential program and merging these two together to provide a brief integrated services for youth and families, really trying to minimize or stop problem behaviors that these youth are exhibiting. There's actually 3 phases to the CIBS program. In the first phase, an intensive in-home therapist goes to the family's home and begins a 2 to 3 week assessment process with the family. In this situation, the therapist is gathering information from both the family, the child, other systems who might be involved with the family, including people like referral sources. It could perhaps be school personnel. Really, wherever the child and family are interacting, we want to know information about that will help us better understand the situation with them. During that 2 to 3 week time frame then, the therapist is formulating their hypothesis or their best guess as to what are some of the things that are affecting some of the current family functioning. One of the most significant shifts you'll see in this type of work is that although we are working intensely with the child, it is really the family system that is the focus of treatment. So by the end of that first phase of treatment, we want to have the RTC answer some pretty specific questions about what's going on currently for the child. The therapist that started in phase 1 will continue during this 30-day time frame at the RTC. What also occurs during this time frame is that the in-home therapist staff works closely with the RTC staff. Oftentimes, RTC staff may be providing co-therapy during this time frame. We'll be providing frequent contact with the family regarding their child's progress there. There's usually 3 staffings that occur during that time frame at the RTC, so the family is well informed about the progress being made there. One of the things to note about this experience is that children within a 30-day time frame typically are not fixed. They are, though, exposed to certain skills and are expected to practice those both during the regular day at the RTC as well as during home visits. And home visits occur on a frequent basis during that 30-day time frame because we want the kids and families practicing the skills necessary to help them be more successful back in the home setting. After the 30-day placement, the child goes back into their home. And then there is, in phase 3 then, it's intensive in-home therapy follow-up, which occurs typically 6 to 7 months following that second phase of treatment. During this time, the same in-home therapist that started with the family continues the work with the family to continue to solidify the gains that were made during the earlier phases, as well as the ongoing work that is necessary to cement the changes that have occurred in a more permanent way with the family. There are 4 partners that are part of this process within CIBS. The first one, most obviously, is the child and the family. The second partner is the children's mental health case manager. Third partner is the intensive in-home therapist, and while the fourth is the residential treatment center or RTC that is involved with the family. What's different from this service compared to services as usual is that all 4 of those entities are expected to be collaborating and working closely with one another to help benefit the child and the family overall. As part of that, there's a high level of communication and collaboration that occurs between each of those 4 systems. What can families, particularly parents, expect different, perhaps in the involvement of the case manager versus services as usual?
So the case manager in the beginning of the placement request assists the family in getting authorization both from the county and the insurance company and get access to the facility. They facilitate arranging for the in-home family therapy and pulling the team together, making sure that there's a schedule set at the very beginning, that during the phase of the treatment where the child's in facility, that the team is meeting every other week. If any challenges come up, the case manager is guiding the parent, where to go to get their answers. If they have any concerns, they can help represent those concerns to any party in the team.
One of the things that families sometimes struggle with in understanding this model is that when a child goes into the 30-day RTC placement, they're often not fixed. 30-day time frame is relatively short, and part of what happens is that the children who go into the RTC are exposed to skills and are asked to practice the skills that will help make them more successful when they get out. But many times parents don't see a significant shift in their child's behavior during that 30-day time frame. Part of that is normal, and wanting to reassure parents that the real work is going to occur between themselves and the child as part of their return home from treatment. Talk a little bit about what families can expect at the RTC when their kids go there during this phase of treatment.
RTCs are typically set up to take care of the needs, really all the needs that children have while they're with us. So they go to school, with us on site, and there's a medical clinic, and sometimes their medications are managed. That's a little bit variable depending on what the decision is in terms of the outside psychiatrists that are involved. But so the child is really living with us, 24 hours a day, and their staff there 24 hours a day, morning and afternoon and all through the overnights. And
right.
So, and anytime there's a significant incident with their child or there's questions, staff are reaching out to families and letting them know what's happening. And so it's not like a child is going someplace and they're absent.
Right.
Really, in many ways, you're getting lots of communication and contact from the staff at the residential setting.
And maybe speak a little more about that, because the expectations obviously for family involvement, again, within that fairly compressed time frame are different. I mean, there's frequent visits, telephone calls. Speak a little bit about that.
With therapists, the work on the units and provide individual therapy for the kids, but the individual therapy is also being provided by the FACS therapist. And there's family therapy that's happening on the outside, as you know, but many times that's happening inside our setting too. So there's sessions happening with the child, there's sessions happening outside with the family, there are sessions happening inside the residential with the therapist on our end. We're all really working together to try to figure out, get the best information we can about what's happening and how to be helpful. So, and our staff are reaching out, and making telephone calls, and our therapists are reaching out and making telephone calls. And so really the communication is pretty intense.
Typically, the therapist is having frequent multiple contacts a week with the family in some sort of capacity. That could be individual, it could be family, it could be couples work, whatever is being worked on that is felt to offer the most benefit to the family in changing problematic behaviors. Tyler and Sarah, you're both therapists who are doing this type of work, and I wonder if you could speak a little to what families, particularly parents, can expect as part of this work with them.
I think parents, families, but parents in particular can expect that that they're going to see a lot of me. It's a we call it an intensive level of services. We're going to be in your home, in your face, talking to you multiple times per week, asking lots and lots of questions, really kind of digging into your business to really, because I want to really get a sense of what your family's culture truly is, what's going on, what works well, what doesn't work well, what are we here to help you change, and really as efficiently as I can dig pretty deep into that and really get a good sense of your family, while at the same time hopefully helping you feel fairly efficiently comfortable with me, that I'm someone you can trust, that you can tell things to that you maybe don't tell to anyone else. You're going to expect to have, again, multiple contacts per week with me throughout the entire process of the program, including while your child is at the RTC. And you're going to expect to have a pretty good education from me at the beginning as to what to expect, what the program looks like, what we want to be focusing on.
I think one thing that I always tell parents is that you can expect at some point in this process that I'm going to upset you.
Yeah, that's good.
I'm going to ask parents to do things that maybe they wouldn't otherwise want to do or haven't thought of trying. So I think that parents can expect to be uncomfortable frequently throughout this process because we're asking family systems to change the way they're doing things.
To really step outside their box.
Right, and I think too, you're gonna see a lot of us, but you're probably all of a sudden gonna see a lot more of your social worker. All of a sudden, you're seeing your social worker and your therapist supervisors. You're going to see possibly their supervisors. So you're gonna be seeing people deeper into the teams that aren't normally the face of the services that you're receiving. And I think sometimes that can be intimidating for families, but it's really just about making sure that the care is on track and it's focused and that things are going according to the model because we know that it works.
They're coming into an intensive therapeutic environment, and so I think the intent is to have them get exposed to a number of therapeutic ideas and to be engaged in a milieu that is closely monitored with a number of professionals and staff to get a good sense about what's the dynamic that's happening with a child and how is that playing itself out with other children, and learn sort of how that also plays itself out in a family. And we get a chance really in a relatively short period of time to have some sort of really learn as much as we can, really present that information back to not only the staff that are working with the child in our setting, but primarily really for the family to be able to give that information back to them, as well as the professionals from VACS who are working with the family on an outpatient basis.
And hopefully parents will see and hopefully it's a good or helpful feeling that they're being included in the process at a much higher level than they might be typically used to with different services they may have had in the past, and that you're not just, as Sarah said, not just seeing us as the face, you're included in staffings with all these other professionals and really getting a sense that there's a whole team of people working toward the goals of your family.
There's a bunch of barriers to overcome. I mean, you have to free families up so that they can work this intensively, so they can, go to the facility and be with their youth and have the in-home worker at home. So in some instances, we do a process called family decision-making, where we ask families to identify the supports in their life, and we bring them together with a paid facilitator that says, okay, during this process, all of a sudden we're making these demands on a parent. Sometimes it's a single parent, and they have other children, and their needs need to be met, and who's going to attend to that? And so we tried to bring a circle of support around families because we know we're placing a high demand on them. Other things, financially, transportation. Sometimes we're helping people with gas or, paying expenses because, this is an intensive, challenging time, and we want to get to the outcome. We want that youth back home. Right. And for me, that's the hallmark of this, that your family's together.
One of the challenges of kids going into long-term residential centers, or RTCs, is that even if a child is successful within the RTC setting, helping to transfer the skills that they've learned at the RTC back in the home is always a challenge. The term for that is generalization. So we want the kid to generalize the skills they've learned back into the home setting, or perhaps other settings such as school that the child may struggle in. That is best done by having the family actively involved in the treatment process, and at times, often due to distance or some of the other factors that can affect RTC involvement, the generalization becomes much more difficult. And one of the things we also know is that a child does best when they stay involved and engaged in their natural support system. One of the challenges, again, of RTC, when you take a child out of their home and place them at an RTC, it pulls them out of their natural support system, which could be immediate family, extended family, friends, neighbors, church folk, whoever, and put them in a somewhat artificial environment with other negative peers, which can create problems as well. So we want to, as much as possible, minimize risk factors and keep a child in the home as much as possible to continue working on the issues and working in the environment where the child is having difficulties.
The difference is families, I think, feel much more connected to that process rather than a more traditional model of a child going to a treatment facility. They're very involved. They're there all the time. We're continuing to do just as many family sessions and meetings as we would if it was all just in home. And having myself and all of the other players that Sarah talks about being involved on a daily, certainly weekly basis, there's you decrease that there's almost no disconnect while the child's out of their home for a short period of time.
We talk about how this can be a process that's jointly made, that it's a shorter term process, and that the results are better, and that they're closer to home. Oftentimes the other RTCs are farther away, and so connecting is harder, and the child's just farther away, and so I think that families have a harder time thinking, oh, how am I going to get up to that city to go and try to meet with my child?
I think a lot of times with traditional models of therapy, it's here's the identified patient, let's just focus on that. And it's really not that way. What we know about kids is parenting influences their behaviors. So if we're trying to improve behaviors, it's more really about the structure and the parenting. So I think parents need to expect that they have a lot of work to do.
Can you maybe just contrast a bit the differences with these types of cases at RTC level? For instance, some of the compressed time frames, some of the questions or assessment done up front, and the specific questions you're being asked to in the RTC portion, some of those things.
You know, it's interesting as we've gone through this, in many ways the process is very similar to families. When we call more traditional residential, it's just much more collapsed. So it's more intense. Instead of a child staying with us on average of 5 or 6 months, which is what a length of stay for us is now, a child's with us for 30 days. And so families experiencing having to be all sorts of new people really quickly, and then learning to sort of figure out how do I trust these people in a really short order to take care of my child during this particular, which is a large, it's not just a hurdle, but it's, you know, it's faith and it's trust, and how do we develop that relationship with them. Same goes for kids. They're meeting lots of people very quickly. Establishing relationships quite quickly, going through a treatment sequence where they're learning, you know, who are these staff and where am I living and what are my goals and what I need to do while I'm here. And then after 2 to 3 weeks, they've gotten some information and they're transitioning back out again. And so we see issues around sort of leaving our setting, which is not unlike what happens when kids stay with us longer. It's just that's the interesting thing for me to watch this. A very similar kind of sequence that children and families go through. It just happens all in that much shorter time frame.
Right. And I think, Mark, if you could speak maybe to, you know, even though the county is the first line of contact usually in this, is the need for kind of repeating the message multiple times regarding the service, what's involved. I know case managers are often involved in ongoing conversations with the family about that. And that's not just a hit them once with this is the program and it's a done deal. Could you talk a little bit about that?
Yeah, many of the families that eventually use CIBS are families that have case management over a period of time. Others may come to us because their child was hospitalized, and during that hospitalization, the hospital refers them to case management, and we get involved at that point. So there's kind of two camps. One is families come to us in crisis, and when assessment is done, either by a community mental health professional or a hospital, recommendations being made that they need a higher level of care. In those instances, a lot of people aren't necessarily aware that we have this model of intervention. And so in those instances, there's education involved with the hospital, with any treatment providers that have been involved in the family, payers, family's insurance company, to say, you know, we have this service that we're having really good outcomes with. And getting all the parties to say, wow, this is a possibility. In some of those instances, residential treatment, just there aren't beds available. And so by starting with systemic family therapy, which is the beginning component of bridging, allows people to kind of get started, even though they might be not totally invested in the idea that they're going to do the full bridging. And they get started and see that beginning of change and have hope that maybe this is the right thing for my child. So there's that group, and then the other group would be families that we've worked with for a while, and maybe they've gone through different crises as their child's gone through different developmental stages or events have happened in their life, and it's an education process. Really contrasting a longer term placement versus this model.
Right. So, given actually the name of Collaborative Intensive Bridging Services, there's a high collaborative involvement, both of the case manager with the family. Could you talk a little more about perhaps that level of involvement with the family?
Yeah, and having a collaborative team means there's a lot of players. And when you have a lot of players, there has to be diligence about staying focused on what the goal is and making sure that everybody's working in the same direction. And so it takes a lot of communication to make that happen. And so the case manager is making contact with all the parties on the team to make sure that things are moving in the direction they need to, and keeping the family informed. If things are changing, they're having that contact with the family. The other role is helping the family overcome any barrier that they may encounter during the treatment process. So asking a family to invest this much time when they have other demands in their life, we want to support them figuring out, okay, who's going to be the resource to support my other children, when I'm spending this much time in therapeutic sessions with the child that's in placement, how am I going to afford to get back and forth? Do I need support with that? And pulling in the family's other natural supports and defining a role that they can have to help the family during this really demanding time.
I'm curious how families have reacted to this, because there are certainly a number of families who the involvement of social services is not something they feel good about, and so may want to maybe distance themselves or not be as much a part, but this really is a process where they're being drawn in more, and obviously case managers are more involved. Can you talk maybe a little bit about how families have reacted to that?
Well, I think some families have been really great and have been really embracing of the process and really want to make change and want to see the family grow and have the child reunify back with them. And then there's other families where, they really don't want you in their business and they really don't want that many team members. There's too many. So that's been the challenge, is really trying to help them understand and clarify for them that this is a short process. We only have 45 days intensely when the child's in the RTC to really address these issues and get at the barriers that are causing the problems with the child's mental health that's keeping them from being safe in their home.
Right.
Yeah, I kind of see it as a balance in two directions. That for some families, it instills so much hope to think that, wow, we can get moving along and have our youth back with us in a short period of time, that the very focused kind of goals helps them think we can do this, and they're hopeful that they can move forward. But it's intense and it's demanding, so that's hard for a lot of families, to think the amount of time that it's going to take over a 3-month period, leading up to, during, and the weeks after, can be a bit overwhelming for people. But I think once they get into it and they experience that change happening right away versus a message that your child may need to live away from you for a half a year or more, it's that balance. I think what we've learned is if you start before a family's totally exhausted, then they're ready to say that it's easier to feel hope. And I think that's one of the strengths of the program, that we're more likely to try this intensive service earlier before youth functioning deteriorates so much, versus the risk of saying, okay, we're going to invest in a long-term RTC and send a child away for 6 months, 9 months, a year, which is a traumatic experience. I think we were reluctant as a county to do that. And so it's kind of a mixed bag. But I think once you get into it, if you can get investment, then families do have that feeling of, we're making change, and we're part of making that change, so they're hopeful.
And this is, I think, the interesting piece of this relatively compressed time frame, is that visits are happening with the family right out of the gate.
Yes.
And
that's a good point, because usually within, 1 to 2 weeks, kids are starting to go home on passes, day passes and overnight passes and 2 overnight passes. So, the contact never really stops.
Right. Yes, and so there's almost that forward momentum. And although the families, there's a bit of a break with the kid being out of the home, there's still a tremendous emphasis on moving forward and the child returning.
Right. Yeah, this is not really transferring a child from the home into an RTC. We take care of all of it. We're frankly it's just adding a new group of professionals who are working with them for that short period of time.
And then by the end of the RTC placement, you're really helping to have answered usually very specific questions that have come in regarding the children's skill set or ability level, and that's being fed back into the treatment process.
Yes, and everybody's sitting at the table and saying, what do we know about this child, and what do we want to try, and what kinds of strategies do we think are going to work, and let's try that and see how it works. Is the child able to incorporate the kinds of things that we're hoping that they can learn in the interactions with professional staff and with kids too, frankly, on the milieus, because the relationships they have with kids is probably as intense as they are with us, because that's just the nature developmentally of children. They connect with each other pretty quickly.
Parents play such an integral role. So I think the shift comes in is, one, you can't expect perfection. It's just not going to happen. We're dealing with human spirit here. It's just not going to happen. And I think it depends a lot upon what happened at home, what kind of quality work happened when the child was away. Did the siblings have any behavior shifts and changes? Did the parents learn any different skills? How are they going to react when the child comes home? And then I think that there has to be a shift. So many times I see families that are so exhausted when we first start that RTC is like, oh, thank God, I need this break. But it's not really a break. So you have to shift the way you're thinking about things, because, like I said, it's going to go so fast. This child is going to come home, and you have to put these skills into motion, and it's not going to be a typical 6-9 year long RTC stay. It's 30 days, and it's hitting it hard the whole time.
As you have seen, Collaborative Intensive Bridging Services provides an effective and intensive way of treating youth with behavior problems and the families they live in. As our model continues to evolve, we look forward to continuing to provide high-quality, integrated care to the families we serve. For more information about CIBS, please contact us at contact@facts, FACTS-MN.org.